Good morning, dear students. Today we will discuss the session 3, group work of the session 3. And of course, you know the units of gases, and we discussed these in the lecture, and we will directly go to the questions. First, let us see the first question about lung ventilation and gas exchange. The question asks, explain the different PO2 and PCO2 value at sites A, B, C, D, and E, and the value given in kilopascal. Why PO2 and PCO2 value are different between these four sites? What are these four sites? The A is atmospheric gases, while B is air in the trachea, C is air in the alveoli, while D is mixed venous blood, means in the blood in the pulmonary artery. So why PO2 and PCO2 are so different in these areas? As you know, in the atmospheric, that is, oxygen is 21%, about 21%, while there is about 0 or negligible amount of CO2 and 0% of H2O. While in the trachea, as you can see, there is H2O added, so it's about 6.28 kilopascal in comparison to the 0 of the atmospheric air, and CO2 is still 0, while O2 slightly decreased. Why these two, for example, different? In the trachea is different from atmospheric air, as we said it, because the water vapor were added, because of the humidity that the airway and the mucus add to the air in the airways. What about the alveoli? In the alveoli, as you know, the normal alveolar gas concentration is PO2 about 13.3 kilopascal, while the PCO2 about 5.3 kilopascal. This is the normal one. After, of course, exchange, why alveolar PO2 and PCO2 and are different from that of the other area of the inspired air, of the expired air, because there is continuous gas exchange. Gas exchange between blood and alveoli, that CO2 added to the alveoli and O2 removed from, and also gas exchange, and also the bringing of the gas from inspired air, continually the air added to it, so O2 added and CO2 removed from. That's why the alveolar air gas is different, why the composition is different from that of the inspired and expired air. What about the mixed venous blood? Mixed venous blood have PO2 and PCO2 of 6 kilopascal. So CO2 is higher and PO2 is lower. So PO2 decrease. Why? Because of the gas exchange with the alveoli. Because it gives this is mixed venous blood because it comes from the tissue, so it brings the gases that are contain the waste products, so bring more CO2 and with less O2. And later what will happen? There will be exchange between the mixed venous blood and alveoli until there will be both the alveoli and the blood become the same concentration. So after gas exchange, PO2 and PCO2 blood will become like that of the alveoli, of 13.3 kilopascal of O2 and 5.3 kilopascal of CO2. So they become the same because of the diffusion until there will be no concentration gradient between them. So in this part, which is the important, this is arterial blood, although it's from pulmonary vein, but it's arterial blood, and this blood is returned to the heart via pulmonary vein in order to pump it then to the tissue in the left side of the heart by aorta. So that's why these are all different. As you know, this is the pulmonary artery, and it's in blue color because it comes from the tissues, while the pulmonary vein, opposite to other system of the body, the pulmonary vein is red, and it brings the oxygenated blood to the heart. This again the same, and this is the same. This is the acinus, the alveolar with the respiratory terminal and respiratory bronchiole, and these are the blood vessels, the capillaries. This is the arterioles, which is blue, mixed venous blood, while the venule, the oxygenated blood. We come to another question, which is say, what is likely to happen to the PO2 and PCO2 in alveolar gas if the person do one of these things? Or what happen if these things happening to the person of an individual? What is likely to happen to PO2 and PCO2 inside C? When it says inside C means at the alveolar gas. What will happen to the alveolar gas? We can look at it and to see if side C is alveolar. Yes. So what will happen to the alveolar gas in the alveolar gas if there is increase in the rate and depth of respiration, or when decrease the rate and depth of respiration? Of course, when there is increase in the rate and depth of respiration, what will happen? Because of the removal of CO2, excessive removal of CO2, the CO2 decrease, PCO2. And because of the taking more O2, because of the increase in the depth and rate of respiration, so PO2 increase. So whenever there is increase in the rate and depth of respiration, which is mean hyperventilation. So in case of hyperventilation, what will happen? There will be increase in the PO2 and PCO2. What will happen when the rate and depth of respiration decrease? Of course, it's opposite to the previous one. What will happen? There will be decrease in the O2, while increase in the PCO2. So it is called CO2 retention. CO2 remain in the air, and also the blood CO2 become like that. So PCO2 increase in the blood also. So this is the answer: hyperventilation, alveolar PO2 and PO2 rise, PCO2 fall, while hypoventilation, alveolar PO2 fall and PCO2 rise. Regarding the third question, this diagram shows a lung unit which is ventilated but not perfused due to a pulmonary embolism, blocking circulation to the affected part of the lung. So if you can see, this is an alveolar and this is the airway or the bronchiole. The airway is intact, no problem, there's no obstruction, while the blood vessel is obstructed, for example, due to emboli, or the thrombus start moving and stay here in one of the blood vessel here in the pulmonary capillary, lodge in the pulmonary capillary blood vessel and cause obstruction here. So the blood flow will stop. What is likely to happen to the alveolar PO2 in these lung units? Alveolar PO2 Chile, Lacuera. What is the alveolar PCO2 likely to be? First of all, what is likely to happen to the alveolar PO2 in these lung units that have a decrease in the blood flow or obstruction of the blood flow? What will happen when there is no blood flow? So there's no gas exchange. Very good. If there is no gas exchange, what will happen to the alveolar PO2? So oxygen is not removed from the alveoli to the blood because there is no blood flow. So what will happen? What do you think to happen? At the beginning, it remains as it was, but when the ventilation is continue and the obstruction of the blood vessel is continue, there will be increasing in the oxygen concentration of the alveoli. Normal alveolar concentration is of PO2 is 13.3 kilopascal, but it will increase until become like that of the atmospheric air. Why? Because the ventilation is continue and taking O2 again and again, while there's no removal of O2, so alveolar PO2 increase until reach to the about 20% of 90.8 kilopascal. What about alveolar PCO2? What will happen to PCO2? You can see the same thing happened to there is no gas exchange. So it will become like that of the atmosphere. So at the beginning, there's no change. At the beginning, it is the same as the alveolar gases. Later, what will happen? So the alveolar gas at the beginning is 5.3 kilopascal CO2, but when there is a continuous ventilation but no perfusion, what will happen? This is mismatch. This will lead to what? Lead to decrease in the CO2. Why decrease in the CO2? Decrease in the CO2 till it reaches to the 0%. Why? It become like that of atmosphere because there's no addition of CO2 from blood to the alveoli. So, and the atmospheric CO2 is about 0%. So the alveolar CO2 become like that of the atmosphere. Why does this situation increase physiological dead space? Why this is called dead space? Why dead space increase in this situation, in this clotting or the imbalance in the blood vessel, decreased blood flow, alveolar ventilation, ventilation perfusion mismatch? Why this is called physiological dead space, this type? What's physiological dead space? Physiological dead space is equal to anatomical dead space and alveolar dead space. Here, the alveolar dead space will reduce. Why alveolar dead space reduce? Alveolar dead space increase. Why increase? You will get more dead space. Why more dead space? Because we have alveoli that is ventilated but not perfused. So we have alveoli that doesn't participate in the gas exchange. You know this is the alveolar dead space. So any alveoli that doesn't participate in the gas exchange, this is called alveolar dead space. So by this, the dead space increase. So these are all the answers. So gradually, the CO2 will be removed until it is the same as in the inspired air. Gradually, O2 added until it becomes the same as that of the airway. Let's come to another question. This time, the perfusion is good, blood flow is good, but what will happen? There will be obstruction in one of the lung unit or pulmonary unit. This bronchiole, for example, is obstructed. What will happen to the alveoli? There will be no ventilation to that alveoli. So let's see what are the questions. What happened to the alveolar air? Let's see, can you explain what would happen to the PO2 and PCO2 in the following area? For example, PO2 and PCO2 in alveoli. What will happen to PO2 and PCO2 of alveolar air? There's no ventilation, but perfusion continue. So when there is perfusion, so the blood continue to remove O2 from the alveoli, the air inside the alveoli that already contained, and continue to add CO2 into that air. So when this is continue and abnormality is not resolved, this will lead to changing of PO2 and PCO2 to that of the mixed venous blood of the pulmonary artery. So the PO2 and PCO2 will become 6 kilopascal because of the concentration gradient will become, there will be continuous adding of CO2 and removal of O2, while there is no addition of O2 and CO2 because of the obstruction of the alveoli. There's no ventilation, so no O2 added. That is what happened to it. What will happen to the capillary blood leaving the alveoli? Okay, we say that the alveolar air become like that of the mixed venous blood. But what about the capillary leaving that alveoli? Normally, the capillary leaving the alveoli will become the same concentration of the alveoli, and normally it is about 13.3 kilopascal PO2 and 5.3 kilopascal O2 of CO2. 13.3 of O2 and 5.3 of CO2. But what will happen when there is, what will happen to this when there is obstruction in the alveoli, or when there is abnormal ventilation, no ventilation to that alveoli? Of course, this it's also will become the same. The PO2 and PCO2 in the alveoli will become like that, of the blood will become like that of the alveoli, because there is diffusion until the concentration gradient there is no concentration gradient. Continue till there is no concentration gradient, and because the alveoli becomes 6 kilopascal of PO2 and PCO2, so the blood that leaving the alveoli is also becomes 6 kilopascal in both PO2 and PCO2, and this is problematic because this blood go to where? To the heart, and it will pump it to the tissues. Why this situation is sometimes referred to as a shunt. Why this is called shunt? Physiological shunt. The other is called physiological dead space, increased physiological dead space, but this one is called shunt. Why is this called shunt? Because here the mixed venous blood will be that are leaving blood that leaving this alveoli that is not ventilated will be mixed with other alveoli that is ventilated and normal, there's no obstruction. So these two bloods, the mixed venous blood will be mixed with the arterial blood, with the venous blood, which is oxygenated blood. So this is called shunt. This is like how we say the heart shunt in the heart, left to right shunt. It is like that. So the oxygenated blood and mixed venous blood will be mixed. So these are the explanation. We will come to the mechanics of respiration. We have a question and ask about put the following pressure in rank order from highest to lowest during inspiration. Which one of these pressure is highest during inspiration? Pressure in the alveoli, pressure at the mouth, pressure in the pleural space. Which one of them is highest during inspiration? I'm not going to discuss this in detail because I prepared a video for you. You can watch the video, short minute video about 3 minutes of the respiratory pressure. It will be discussed there. So what will happen to this? Which one of them is the highest during inspiration? Of course, during inspiration you have to do what? Inspiration, flow of air from outside to inside. So which pressure should be highest? Then which one? Then which one? Of course, every time the pleural pressure in the pleural space is the lowest because it is negative. So this is the lowest. But what is changed is that of the alveoli and mouth according to whether it is inspiration or expiration. And let us see the other parts of question. How will the above order change? So the order of ranking of these from highest to lowest of this pressure change when there is a quiet expiration to resting expiratory level. So during expiration, what will happen? And what will happen, or which pressure is highest, or what are the order of this pressure from the highest to lowest in case of forced expiration. During inspiration, of course, mouth pressure should be highest for air to flow from mouth to alveoli. So mouth, alveoli, then pleura. Put pleura at the end. So it's the lowest pressure because it's negative. During quiet expiration, it's opposite. We need air to flow to outside. So the pressure in the alveoli should be higher than that of the mouth. So alveoli is more than mouth pressure and more than pleural pressure because pleural pressure is negative. But what will happen during forced expiration? During forced expiration, what will happen? The pleural pressure could become positive, but it is more than the mouth pressure because forceful expiration, as you know, by extra muscle contraction. So the great pressure, there will be the pressure become positive here. And what will happen by the force on the pleura of the abdominal content on the diaphragm, this will happen, and it become more than mouth pressure, while it is still less than alveolar pressure. It never become, it shouldn't become the more than the alveolar pressure. If it is so, there will be collapse of the lung. So it is still negative in regard to the alveolar pressure. As you can see, these are the pressure difference. So during forced expiration, alveolar pressure is highest, then pleural, then mouth pressure. You know, this is the pleural space and the pressure here. Then we will come to the sixth question. What will happen to the lungs if air is introduced into a pleural space? What is this condition called and how might you treat it? If air enter into the lung, introduce into the pleural space of the lung. For example, during the stab wound, injured by due to an injury, an accident, the pleural space injured and air enter into the pleural space. Why if the pleural space when it's injured air enter into it? Because it has negative pressure. Because it has negative pressure, it sucks air into it. Atmospheric pressure is high, very high than that of the pleural pressure. So the air will move from the atmospheric to the inside the pleura until they become equal, until the atmospheric pressure become equal to that of the pleural pressure, because there is opening in the pleura. What do you think happened to the lung? I think you know, of course, there is collapse. What this condition called? This is called pneumothorax, because of air, presence of air in the pleural space. That's why this is called pneumothorax. Pneumo means air, pneumothorax. How you might be treated, how you can treat this patient? If you have a patient like this, what do you think we have to do? We have to remove this air. Because the problem is this air that causes the collapse. This is a knife, for example, penetrating the pleura, the lung, and cause injury in the pleural space opening. The air will move in until the lung becomes so small like that. Could you see? And this is according to the severity of injury, the amount of injury. If the opening is small, could be less. If it is treated earlier, there could be no major collapse like this. So according to the amount of air entered, the amount of the opening and the time, the duration. So the lung could become like this because of the atmospheric pressure. You remember we said pleural pressure should be always less than that of alveolar pressure, but here the pleural pressure become like that of atmospheric, become very high. That's why it will cause collapse of the lung. So we have to put a tube here in order to, a tube that is connected to, it's called chest tube, to a drainage that goes the suction of the air in the alveoli. And sometimes they can use the negative pressure, and this is important to remove the air there. So this again, this is the pressure that air, atmospheric air, creating on the lung and goes collapsing of the lung. This is the chest tube that put there, and this chest tube is, you can see here, it will put here, mostly at the top of the lung, and the pleura in between, of course, in the pleural space, and the air will be sucked here into these tubes, into a drainage system. This is the wall suction, create a suction until it will remove the air gradually, and it will remove the collapse, or treat the collapse, or treat the pneumothorax and prevent further collapse, or treat the collapse of the lung. This is the treatment of pneumothorax. What will happen to the resting expiratory level? Do you know what's resting expiratory level? It's called resting. What is resting? Resting means resting state of the lung. You know what's resting state of the lung. Resting state of the lung is the functional residual capacity. What will happen to the functional residual volume or capacity, or resting state of the lung, or the amount of air that remaining in the lung after normal expiration? When the lungs become stiffer because of development of fibrous tissue, when there is development of fibrous tissue, excessive formation of the fibrous tissue collagenous fiber, when there will be increase in these tissue, fibrous tissue, what will happen? The lung becomes stiff. So, what do you think happened to the functional residual volume? of course, all lung volume will decrease. So all lung volume will decrease in case of fibrosis or when the lung becomes stiffer. What will happen to the lungs if, what will happen to the resting state of lung or this volume, the functional residual capacity when the lung become more compliant, when the lung become easily stretchable. In this lung, mostly they are associated with what? With increase in the lung volumes. So what will happen to it? There will be increase in the functional residual volume, all volume of the lung, most of the volume will be increased. We discussed the lung volumes here, and this is the restrictive lung disorder or fibrosis. All the lung volumes decrease. You can see here the lung. This is the normal lung. This is the stiff lung. It becomes smaller like this. That's why vital capacity decrease. The tidal volume, the residual volume, all functional residual capacity, total lung, all of the volumes are decreased. While in the obstructed lung, especially those with a severe lung obstruction or emphysema that associated with increase in the compliance, what will happen? There will be increase in the residual volume, increase in the functional residual capacity. Why resting state of the lung increase? Why residual volume increase in this case? It will increase because the person, there is air trapping, air remaining in the airway, in the alveoli. The air remaining there, this will cause expansion of the lung, and also at the same time, this will prevent further taking of air, or the vital capacity will reduce at the expense of the residual volume and functional residual capacity. So the air remaining in the lung will become higher. All the lung volume will increase. We'll come to the next question. In what condition will the lungs become easier to stretch? You know, we discussed this a lot. Emphysema associated with increase or destruction of the elastic fiber, so decrease in the recoil pressure, so easiness of stretching will be increased. So in the emphysema, this will happen. What might happen to the functional residual capacity if narrowing of the small airways makes it more difficult to force air through them when they are compressed during expiration? When we have a narrowing of the airway and compress it during expiration, what will happen to functional residual capacity? First, what's functional residual capacity? The air remaining in the lung after normal expiration. So, what do you think? What will happen to this air that remaining in the lung after normal expiration? Increase or decrease? We do expiration, but there is narrowing of the airway. There is a pressure on the airway during expiration, compression. What will happen? Of course, the expiration decrease, or the volume of air that expired decrease, or there will be slow because of this compression on the airway. So this will cause increase in functional residual capacity. The air remaining in the lung increase because the airflow to the outside, or the volume of air that go to the outside decrease, or the speed of the air that go to outside decrease. So there will be increase in the functional residual capacity. What effect will this change have on the shape of the patient's chest? This is the same as the case of the emphysema, that we see increase in the compliance because of the obstruction. We can draw it here. When you can draw it like that. When the air try to go outside, keep this in mind. Most of the time, we have problem during expiration in the small airway. During expiration, the flow is affected more. And in case of the asthma, COPD, and so on, these cases are mostly when they put stethoscope on the patient's back, they say that they will notice during expiration that have problems that have wheezing and other sound. Why during expiration? Because during expiration, first you can see here the alveoli are so numerous, they are great in number, and when they try to come to the narrowed airway, This is like an obstruction. It is difficult for this air to come from this large wide area to go to this narrow area. And also there is compression here. The compression during expiration is more. As you know, during expiration, the pressure here on the outside is more in order to increase the pressure in the alveoli and in the lung. So there is more compression during expiration. While during inspiration, we do not have problem in the bronchial or smaller bronchial, because the air will come from what? From the narrow area to wide area, and there is no so problematic, and also there is no compression of the airway, or the compression is less. So if the airway is normally narrow, when the airway is narrow by disease, and there's a normal compression during expiration, so the problem is mostly during expiration in the smaller areas. Okay. So when this happens, there will be formation of barrel chest. When this continue happen and it is not resolved, or this condition is continue, of course emphysema, it is progressive, and the shape of the chest of the patient in the severe emphysema become like this. This is called barrel chest. Could you see how much big it become in comparison to this normal one? Barrel, look, per milliliter.